Hi guys, welcome back to the INICET Medicine PYQ series, episode 3. In this series, we are discussing the previous year questions which have come in the INICET exams so that you can have a quick revision of the questions. So let's get started. So the first question, which of the following is used in the treatment of hypercalcemia due to vitamin D toxicity? And options are dexamethasone, hydroxychloroquine, chloroquine and ketoconazole. So steroids are known to block calcitriol production, leading to decreased calcium levels by reducing intestinal calcium absorption and increasing the urine excretion of calcium. So among the options, dexamethasone is a steroid which can be well used in the treatment of hypercalcemia due to vitamin D toxicity. Other options are not used in treatment. So the best answer here is option A, dexamethasone. Next question, which of the following is not a treatment option in Guillain-Barré syndrome, that is GBS? So the preferred treatment in GBS is IVIG and plasmapheresis. Ventilator support is also needed in about 30% of cases where respiratory depression is seen. But steroids actually have no role in treatment of GBS. So the best answer here is option A, steroids, which is not a treatment option in GBS. If you want to quickly revise GBS, I have made a video on GBS. You can watch them later. The link is in the description below or you'll find it in the I button. Moving to the next question, a patient who is intubated had an X-ray done and the radiograph is shown below. What is the next step in the management of this patient? And options are suction, chest physiotherapy, start antibiotics and send samples for culture, and ultrasound guided aspiration. So first of all, if you see the chest X-ray, it shows left-sided pleural effusion. So suction is not the treatment. Option B, chest physiotherapy. So it is done basically during the recovery phase of the illness and not initial step. Coming to option C, start antibiotics and send samples for culture. So this has to be done as a part of pleural fluid analysis and treatment, but this is not the immediate next step. Coming to option D, ultrasound guided aspiration. So this is the answer, which is the next step that should be done both as therapeutic and diagnostic pleural fluid tap under ultrasound guidance. So option D, ultrasound guided aspiration, is the best answer. After which starting antibiotics and sending the sample for culture is a part of treatment. And as a part of recovery, chest physiotherapy is definitely recommended. But among all, option D is the next best step in the management of this patient. Moving forward, which of the following is false about Mycoplasma pneumoniae? Option A, responds well to amoxiclav. Antibody are useful in diagnosis. Chest X-ray shows bilateral infiltrates and it can be cultured in a cell-free medium. So if we go to the option, responds well to amoxiclav. So Mycoplasma pneumoniae lacks cell wall and amoxiclav is a beta-lactam which acts on the cell wall. So it shouldn't respond well to amoxiclav. So this looks as a false option. Let us go to the other options as well. Option B, antibody are useful in diagnosis. So yes, it can be detected by serology, by IgM or IgG levels. Option C, chest X-ray shows bilateral infiltrates. So Mycoplasma pneumoniae is known to cause atypical pneumonia. And a feature of atypical pneumonia in chest X-ray is bilateral infiltrate. So this is also correct. And option D, it can be cultured in a cell-free medium. So yes, Mycoplasma pneumoniae can be cultured in a cell-free medium called PPLO. So this option is also correct. So after going through all the options, we know option A, responds well to amoxiclav, is the false option because Mycoplasma lacks cell wall and amoxiclav acts on the cell wall. So this is the correct answer here, option A. Next question, a 50-year-old chronic smoker presented with mild recurrent hemoptysis without fever or weight loss. The chest X-ray appears normal and the sputum is negative for AFB. Which of the following is the most useful diagnostic investigation? Options are MRI, CT, fiber optic bronchoscopy and bronchography. Now in such a patient who is a chronic smoker presenting with recurrent hemoptysis and also whose chest X-ray appears normal and sputum is negative, MRI is not useful unless we are suspecting a Pancoast tumor. Option B, CT. Yes, this is a better option after chest X-ray because CT helps us to identify any mass, parenchymal lesions, exact location and better anatomy of the structures. So this can be useful. Going to the other options, option C, fiber optic bronchoscopy and option D, bronchography. So fiber optic bronchoscopy is always done once CT is conclusive and biopsy is needed to be done. So FOB will not be useful here. So the most useful diagnostic investigation in such a case will be CT. So the best answer here is option B, CT. Moving forward, next question, the serum electrolyte values of a patient weighing 60 kg are given below. Calculate the sodium deficit in the patient and following values are given. Options are 20, 200, 400 and 720. So first, to answer such question, we should know what is the formula for calculating sodium deficit. So the formula is target sodium minus sodium before correction into 0.6 into body weight in kg. So if we substitute the value, target sodium is 140, sodium before correction as it is given, it's 120 into 0.6 into 60, that is the body weight, and if we calculate, the answer comes out to be 720 milliequivalent. So this is a very straightforward question. If you know the formula, you can answer such questions. So the correct answer is option D. Moving forward, next question. Resistant hypertension is defined as, options are BP more than 160/90 with one antihypertensive, BP more than 140/90 with one antihypertensive, BP more than 160/90 with 3 or more antihypertensives, and BP more than 140/90 with 3 or more antihypertensives. So to answer this question, we should first know what resistant hypertension is. Resistant hypertension is defined as BP more than 140/90 despite on 3 or more antihypertensive drugs, with one of them being a diuretic. So if we see the options having one antihypertensive are ruled out. We are left with option C and D, and the value we know it is 140/90 and it is not 160/90. So this is a very straightforward question where resistant hypertension defined as option D, BP more than 140/90 with 3 or more antihypertensives. So this is the correct answer. Moving forward, high anion gap acidosis with low bicarbonate levels is seen in all of the following conditions except renal disorders, diabetic ketoacidosis, lactic acidosis, and salicylate poisoning. So if you see, all of the options are associated with metabolic acidosis, but they have asked high anion gap. And if you see option B, C and D, all three are causes of high anion gap metabolic acidosis except option A, which is a cause of normal anion gap acidosis. So to answer such questions, if you know the causes of high anion gap, normal anion gap, it becomes very simple. So the answer here is option A, that is renal disorder, which causes normal anion gap acidosis. If you want to quickly revise the acid-base disorders, I have made a complete video on acid-base disorders, the ways to approach such questions, comparison between high anion gap and normal anion gap metabolic acidosis, along with many practice questions. So you can definitely watch them. The link I'll provide in the description, or you can watch from the I button. Moving forward, which among the following is the most severe manifestation of CKD? Options are decreased GFR, increased creatinine, hyperkalemia, and proteinuria. So if you see option A, B and D, all are complications of CKD, but none are life-threatening. But option C, that is hyperkalemia, it can lead to cardiac arrhythmias and even sudden death. Hence, a severe and life-threatening complication of CKD is hyperkalemia. So the answer here is option C, that is hyperkalemia, which is the severe manifestation of CKD. Moving forward, a patient presented with massive abdominal swelling. Paracentesis fluid was sent for lab analysis and results show serum protein to be 3 gram per dl and ascitic fluid protein to be 1 gram per dl. What is the likely diagnosis? And options are congestive heart failure, early Budd-Chiari syndrome, late Budd-Chiari syndrome, and tuberculosis. So to answer such questions, we have to calculate SAG value. By SAG, I mean serum ascitic albumin gradient. So here in the question, they have given the values of serum protein and ascitic protein. So we just have to minus serum albumin minus ascitic albumin, which is 3 minus 1, which is 2 more than 1.1. So anything equal to or more than 1.1 is high SAG and less than 1.1 is low SAG. So in this option, we know it is high SAG. So option A, B, C, they are causes of high SAG ascites. So they are possible options. And option D, it is mainly found in low SAG ascites. So option D, tuberculosis, rules out. But if we see again the ascitic protein levels, it is given 1 gram, which is less than 2.5. So option A and option B rules out, and option C is the correct answer. So to answer such question, you should have an idea regarding the SAG values and how they are classified as per the protein levels, and this table can help you come to the answer. So the correct answer here is option C, that is late Budd-Chiari syndrome. Moving forward, next question. A newly diagnosed HIV patient presented with fever, cough, hemoptysis. His sputum sample show acid-fast bacilli. What is the appropriate management for this patient? And options are start ART if CD4 less than 200, start ART and then ATT after 2 weeks, start ATT and then start ART after 2 weeks, and start ATT and ART simultaneously. So from the question, we understand it is HIV and TB co-infection, and such a situation, always ATT is started first, followed by ART after 2 weeks. This is to avoid an entity called IRIS, that is immune reconstitution inflammatory syndrome, which is characterized by fever, lymphadenopathy and worsening of symptoms, and this occurs due to simultaneous administration of ART and ATT. That's why they are avoided. and this ATT started first, followed by ART after 2 weeks. So option C is the correct answer. This is a very important question. It has been repeated multiple times in both INICET and Neet PG. So kindly remember this question. Moving forward, the last question. During the discharge of a COVID patient who was treated with steroids and remdesivir, which of the following will you inform the patient about? Options are repeat RT-PCR after 7 days of discharge, watch for persistence of anosmia, watch for headache and nasal discharge, monitor glucose levels, and watch for sinusitis-like symptoms. So this is the multiple correct answer type questions which is expected in INICET. And among the statements 1 to 5, more than one are correct. So if we go to the options, repeat RT-PCR after 7 days of discharge is not recommended by government anymore. Once a patient is diagnosed as COVID, they are treated as per mild, moderate and severe, and even after discharge, repeat RT-PCR is not needed except for home isolation. Statement 2, watch for persistent of anosmia. So this is not a severe symptom, or it doesn't suggest any life-threatening symptom. So such advice is irrelevant. Statement 3, watch for headache and nasal discharge. Yes, this is important because it could be early symptom of mucormycosis. Then monitor glucose levels, definitely, because patient have been given steroids and blood glucose level might fluctuate. So monitor glucose level is important. And watch for sinusitis-like symptoms. So again, this is also important symptom which could be an early symptom of mucormycosis. So statement 3, 4 and 5 are important advice which need to be given to a patient of COVID-19 who have been discharged and treated with steroids and remdesivir. So if you see the options, option C have statements 3, 4 and 5. So this is the correct answer. I hope guys this series is helpful and I hope you are studying well. Keep solving MCQs, keep going through the previous year question topics, and I'll see you in the next one. Cheers.